There are different types of clinical reasoning that are vital to know in order to properly assess a situation with a client and to be able to provide them the help they need. Life is complex, and because that's the case, life needs complex solutions. And it's not enough to think about a problem in a unidimensional way. If it's clear to you what the issue is, it's not actually true. The issue is clear to you. So these several different clinical ways of defining a problem are necessary, just in terms of being more complex, more real, more in touch with reality. That's number one. Number two, being able to have different methods of clinical reasoning is a good way of triangulating what you're going to end up doing with the client. Life, like I said, is complex, and what that means is that there's a lot of potential. You can do anything. And chances are, whatever you do will be helpful in some way. Now, obviously, some approaches can harm a client, and fair enough. But the question isn't how do I help this person? The question is how do I help this person most effectively? So by triangulating the different perspectives in clinical reasoning, you can more accurately and effectively treat your client. The first type of clinical reasoning is content knowledge. Now, this is pretty straightforward. What this basically means is all the stuff you learned in university and hopefully you're continuing to learn today. It's this mass amount of information that is required to be able to just sense what direction to go. It's the doors you can open up and go through. And the more information here you have, the better. This is going to be, clinical work. People have to have a background, certainly, in being able to know and understand different psychological problems, but that's not enough. We have to also be philosophers, ethicists, anthropologists. We have to have a fair understanding of cognitive science, of behavioral science. We have to understand how affect neuroscience works. We have to understand how the brain works, and all these different fields we're not going to be experts in per se, but we have to have a broad enough knowledge base where we're rooted in reality. The second type of clinical reasoning is procedural knowledge. Here, the difference between content and procedural is in actualization. Your question here is, what are the steps necessary to treat this client? It's more cause and effect based. So you're creating a hypothesis of what the problem is, and you're beginning to think how you'd go about solving this problem. What are the steps that you can take procedurally in order to resolve the problems for your client? The third is diagnostic reasoning. Here you're going to be drawing upon all the knowledge you have of manuals like the DSM, or the psychodynamic ways of defining mental health. Basically, what you're doing here is you're drawing upon a pre-organized, a predefined problem, and you're matching, so to speak, your client in the manifestation of whatever's going on in their life to the issues at hand. The next is interactive reasoning. This one's important because you're taking all of the general knowledge, content, procedural, diagnosis, that we already covered here, and you're trying to refine that information with the unique information of your client. You're speaking with him or her about their life experience, what they feel, what they think, how these problems, which you're already hypothesizing, are manifesting. This approach is beginning to tailor-make your clinical knowledge and apply that specifically to the client. The next is narrative reasoning. Narrative reasoning is taking one step further in terms of tailor-making your intervention for your client. Now that you have this unique information, have a sense of the life context of your client, you're organizing a narrative where there's a beginning, middle, and end. There's a motivator. What is motivating your client to live the way that they are? What are the outcomes of that way they're living? And ultimately, how is this leading towards their suffering? There's a beginning of the story, a middle, and an end. And in understanding this narrative, this life story of your client, you're now taking technical information, you're translating it into a human context. We're not machines. While psychology is a science, It's not a hard science, and we're going to have to try and translate all the things we know into living, breathing people. And this strategy is really where you're going to be doing that. The sixth is ethical reasoning. This one's incredibly important, and depending upon your clinical background, this may very well be your overriding principle in how you're treating your client. But certainly it's going to be one of the more important ones just from a practical standpoint. Ethics is the practice of being confronted with two different values that you have to choose from. Maybe you can only choose from value A, maybe only from value B, maybe a mix of A and B together. But you're having to make a moral decision how you're going to proceed in treating your client. You, at this stage, at this level of clinical reasoning, are being put in the picture. As Skinner put best, we only understand what is important to us through the eyes of other people. There is we are bound together in our experiences with others where we're playing off each other. There's no such thing as a pure observation. The client is influencing you and you're influencing the client, and the loop goes to infinity, back and forth. So you are involved, your beliefs are involved, your ethics are involved, number one. Number two, just on a more basic level, clinical psychology, treating people with mental health issues, is by definition an ethical act. The question is, how can you live better? That requires value judgments every step of the way. And finally, the way the ethical reasoning comes into play here is in how you confront your limits. Ethics, like I said, is competing value judgments. And value judgments have consequences that limit our actions. Whether or not you're working as a private clinician or you're working in a group, you have restraints. And it's quite often the experience of beginning clinicians and interns that they get pretty angry. Why doesn't an organization have more resources? Why can't we spend more time with our clients? It's not fair. There's a bitterness that begins to develop, a resentment that begins to develop with neophyte clinicians. And that, I think, in large part is due to the fact that they're confronting ethical choices without realizing it, without owning the ethical choices that their organization must make and they themselves have to make. So within this angle of ethical choices, we're thinking about, we may not be able to help this client who has borderline personality disorder fully. We might not have a full DBT or a psychodynamic, psychoanalytic approach available. Maybe we don't have well-trained CBT clinicians here. We have limits with who's working on staff, number one, and number two, we might have limited time. I can't help this person all the way. It might only be that I can do casework, unfortunately. I won't be able to improve their relationships directly necessarily. I might not be able to help them with their symptoms, all of their symptoms and how they manifest, but I might only be able to take care of one or two. But that'll be helpful in moving this person forward. And thank God life is long. You're not the one who has to solve all the problems of your clients, although that would be nice, and it is an ideal. It's not a silly goal to have. But again, ethical choices, these competing values, the restrictions that life has by definition, because that's what it means to be in the world. The world is a world of limits. We're going to have to make tough calls, and this type of clinical reasoning is going to be the best way of sorting that one out. The seventh is teaching as reasoning. Some clinicians have a difficult time teaching their clients. They kind of feel like they shouldn't be putting too much of themselves into the picture. Jungians, from a psychoanalytic perspective, have no problem teaching their clients. Stories of Jung, being knee to knee with the old man. He had no problem being the one who talked most through the session and telling the clients, this is how it is. Behavioral therapists are the same way. in terms of teaching their clients how to increase motivation, how to better habituate themselves to new behaviors, to execute what needs to be executed. That is fundamental to that particular approach as well. Humanistic approaches, okay, not so much. Some psychoanalytic approaches don't want to take this as much of a teaching role, and fair enough. Interpretations are a type of teaching, but not as intensive as, say, the other examples I gave you. So teaching is one very valid way of reasoning out clinically what's going on with your client. Another angle of this is the teaching opportunities you get from other clinicians, what you're learning from manuals, what you're learning from workshops. That this is going to be enhancing your clinical work, and here you're on the receiving end of teaching as reasoning. Another approach is inductive reasoning, where you're collecting many specific examples of behaviors and you form a hypothesis. The reverse to this is deductive reasoning. Not an exact opposite, but where your starting position is from a known stance, a known view of the client, and you're interpreting their actions based on this general interpretation of them. The next is categorization as reasoning. Categorizations are extremely important. Like I said, the way we live in a world of restriction, of limits, and we simply can't hold everything. We have to filter out the infinite amount of data that we're absorbing in order to make what's in front of us useful. It's worth noting on a biological level, this is exactly how vision works. This is exactly how we, on a biological level, process data, that we're looking for what we know, and we're actively, not just passively, but we're actively filtering out everything else around us. And this is adaptive. Quite clearly, we're alive today. It seems to work. From an evolutionary standpoint, it is adaptive and useful, and that's exactly going to be the same sort of phenomena we're going to be seeing in clinical reasoning here, with making categories that we're limiting possibility. We're making choices of what's in front of us. We're making comparisons and we're contrasting in order to simplify the case enough so that we can choose to act in a specific way and see if that'll be effective. The next is pragmatic reasoning. This type of reasoning is solely concerned with creating outcomes which are going to be effective and increasing the well-being of the client only. It is going to be very case specific. How can we make this thing better? The next is predictive or conditional reasoning. Here what we're trying to do is we're taking all the information we have of the client, we're trying to project what we can realistically achieve with them. Usually this is going to be manifesting after an intake where we have all this information and we begin to negotiate with the client exactly what you believe as the clinician you can achieve. As a sidebar here, it's important to communicate the future to your client. They're coming in helpless and hopeless, and they're looking to you to provide answers. Now, this can be uncomfortable. Some clinicians kind of want to throw that back on the client, that this is your life, and part of that's true. At the same time, you are an expert, and being able to accurately, effectively, and clearly communicate, guess what? You have come to the right place. This is not a waste of time. I will be able to help you, and this is, generally speaking, what treatment will look like, is infinitely helpful in providing them hope and a purpose to keep seeing you, to keep fighting to solve the problems that they face in their life. This is referred to as positive expectations. In the clinical research, you want to do that. You really should be able to say to your client who's coming to see you, I can help you. If you can't say that, don't see them. You're not qualified. It's really as simple as that. We wouldn't see a doctor who, I have heart problems here, clogged arteries. I don't know if I can sort this one out for you. We'll have to see if we can do this together. You wouldn't want to see that cardiologist. You wouldn't want to see that heart surgeon. So the same thing here. Own your profession, own your skills, and transfer your own clinical assuredness to your client. The next is integration of knowledge as reasoning. Here, this is a type of a symbiotic way of learning and growing in your clinical work and being able to make the decisions you need, where you're taking, the content information, the abstract, book stuff that you're learning, and you're refining it, you're making it real, you're giving it legs in the practical experience that you've developed. So it's a type of editing work on the content information you've learned artificially. The next is interpretive reasoning. If clients are going to come in, they're going to tell you a lot. And while we have to gather in as much information as we can to preserve as best we can the way this information is given over to us, we have to be judicious in how we interpret this information. Everybody has blinders. Everybody is limited in their understanding of themselves just by definition. I said earlier, what's important to us is what we see, and what that means is we miss a lot. We also are confronted with the problem of life experience, that people go through life just assuming certain things are normal. Well, isn't it normal to be hit by mom and dad and screamed at that way? Well, isn't that how everyone grows up? We have limited knowledge, with the clients are coming in with this limited knowledge, and we have to be able to interpret their descriptions with the broad knowledge that we have from all the types of reasoning that we've developed, all the information and research and work we've done, in order to get a clearer picture, to translate the picture that the client is giving us into something that we can recognize in order to improve. The last type of clinical reasoning is collaboration. Here, the question is, how best can we not just help the client based on our knowledge, but how will the client recognize he's being helped? Clients are people just like you have your own values, your own definitions, your own assumptions. So does the client. And that has to be brought to bear into the work, because if you're not answering their problem, they're not going to continue working with you and get the help they need to improve their life. You may very well see the problem in a marital situation as the couple is just too darn volatile. But if what the client really wants is more date days, they feel ignored, they want to have more exposure to their spouse, they want more FaceTime with their spouse, well, it really doesn't matter so much, practically speaking, that you think, and you're probably right, that, man, do they just yell at each other and fight like cats and dogs? It doesn't matter. Because the way that this client is interpreting his problems is through this lens of, I just want more FaceTime with my spouse. I really love them. Now, those are the 15 methods of clinical reasoning. The ideal here, again, is you want to be able to frame your work with each client through all 15. In some, it's going to be like with inductive or deductive reasoning, they're going to be at odds with each other, so there's a refinement going on, and using these in conjunction with one another, content, procedural, pragmatic reasonings are going to be more linear. But in general, the main idea here is all 15 are going to be enriching your understanding of the case and making you a better clinician.